Thanks very much, Ian. So we're going to move into the next session and focus on osteoarthritis in athletes. And I would like to invite the first speaker to the stage. And so it's Professor Sean Glyn Jones from Oxford. And he's going to talk to us about osteoarthritis, treatments, and potential cures for the future.
I hope you can all hear me. This is a very broad subject, so I've got my work cut out here. But probably the best thing to direct you to is the recent Lancet seminar on osteoarthritis. And this shows what a complex issue and what a multifactorial issue OA is. This is the diagram that they put in the publication, and it shows that OA has several different postulated causes. Surgeons believe it's mechanical. Many other physicians believe it's inflammatory, genetic, epigenetic, but we all believe there's environmental factors as well. We also have different philosophies in the way we treat osteoarthritis. We seem to be trying to achieve different things according to our medical subspecialty. So if you're a physician, you may be looking at pain reduction. Obviously, surgeons are looking at pain reduction, but they also claim when they discuss with our patients that we aim to limit arthritis, prevent it, replace the joint. So there are varying conflicting, I suspect, outcomes within the medical community. There's also a difference, again, if you read papers like this, in terms of the philosophy of what we believe osteoarthritis is. Is it a single joint disease that varies according to the joint? In other words, knee arthritis has a different cause to hip arthritis, or is it a whole body disease? And the truth is, none of us know the answer to all of this. So what I wanted to talk about, rather than what could cause general arthritis, is a bit about what I know about, which is osteoarthritis of the hip. And we've done a fair bit of work over the years trying to look at the causes of this. Now, we know hip replacement's effective. We've got a very good treatment. It's one of the most effective treatments, actually, in surgery. However, obviously, most people we see don't require hip replacement. It's too early. But before about 2000, and there were a few enlightened people who realized it, most hip OA was thought to be idiopathic. In other words, we didn't know the cause. But now we know that over 80% of hip replacements have some sort of minor deformity that may confer an increased risk of arthritis. So in other words, they've had a deformity that's caused their end-stage arthritis. So what are the causes? Well, they are, if I can get this to move on, mainly, although there are others, but mainly hip impingement, which is on the left-hand side of the picture there, and sorry, the videos refuse to play, and DDH, or developmental dysplasia of the hip, but milder forms, not the frankly dislocated forms that we see at birth with congenital dislocation. So how common are these? Well, they're actually very common, and if we look at cross-sectional studies, we find that roughly 20 to 25% of the general population have some form of deformity in the hip that might be linked to arthritis. There are big studies from Scandinavia, from Europe, and from the UK that all show about this sort of level of deformity within the population. We also know that in sports people, these deformities are more common, particularly FAI. And there's been a lot of work over the years on the prevalence of FAI in sporting populations. Depending on the type of sport you do, then you might have a very high risk of developing FAI. And we see that very commonly in soccer, in NFL players, in ice hockey. But there are various other sports where it's been quantified as well since. And we know that the population at risk is quite high because in some of the sports, such as soccer, such as rowing, there is quite a high prevalence in the population of doing these sports. So what is the association between these deformities and arthritis? What evidence do we have to show that they cause arthritis, or at least link to a higher risk? Well, this is a study called the Chingford study, which was done years ago, and was a longitudinal study looking at the probability of developing arthritis if you have the deformity that's associated with FAI, so a CAM deformity. And you can see here, this is alpha angle, which measures the size of that deformity. And above about 80 degrees, you see an exponential rise in your risk of arthritis and hip replacement. When we look at the shape of the hip socket, you see a similar association with deformity and increased risk of arthritis 20 years later. So here you see, as your shucket gets shallower, you can see a significant increase in the risk of hip replacement and osteoarthritis. There's a weak association with a deeper hip socket, but it certainly does seem to confer an increased risk. So people have looked at these data sets and combined them and repeated them. And actually, there's a fairly good consensus now, and some of it produced in reasonably good literature like Nature, that actually there is a significant increased risk in arthritis with both increased alpha angle, but also reduced lateral central edge angle. We've also looked at when hip deformities develop. So this is an academy football player from Southampton whose hip is pictured here about the age of 10, and then we can see it develop into adolescence and adulthood. And we followed a group of these players a few years ago. It's called the FAME study, and compared them with kids, and found that before the age of about 11, you didn't have a cam deformity. But at about that age, particularly in the higher activity individuals up here, you saw significant proportions developing deformities in their hip. So can we modify arthritis now that we know when they happen, we know what causes them, and it seems to be a mechanical problem in the hip? I suppose in summary, we're not sure at the moment. What have we done? Well, we've looked at trials with FAI surgery, and we found that if we do cohort studies, less of them after the surgery seem to have a lower risk of having a hip replacement. There are some studies that have looked at using Degemerate, which is a functional MRI scanning technique that measures cartilage quality, and they haven't found any difference if you do FAI surgery on these patients. We've looked at it in Oxford, and in our FATE study, which is a national trial, an RCT, on hip arthroscopy, and we found that there is some early suggestion that you may reduce your Schomri score over a 3-year period if you remove the bump on these patients. We can't really tell whether there's a target at the moment for developing children's hips. There may be some evidence coming out of, this is data produced from NYU, from Sandra Sheffield-Breen's group, that the stresses on your hip joints confer the risk for developing the deformity. So it seems that torsional forces at critical stages of development will give you a higher risk of developing a cam deformity. Now, there's no evidence as yet that reducing those torsional forces is possible, but there's work ongoing at the moment looking at whether this could be at one stage an intervention that could be developed to minimize that risk. You can also look at perhaps advising adults once they've developed the deformity. This is a 4D CT scan that articulates the hip in the real patient doing their particular type of sport or activity. These are now becoming standard on most CT scanners, and it may be that we're reaching a stage where we could actually give some individual advice to players or to just the general population on what is causing their impingement and what activities they should avoid. Is there any evidence that physiotherapy or any other non-operative techniques can modify arthritis? Well, the answer is probably not at this stage, although they do seem to be hugely effective, certainly at the early stage of FAI, of managing pain. What about developmental dysplasia? Well, PAO is actually a very effective technique. It has huge improvements. This is the non-arthroplasty hip registry data, showing that you get good response to surgery, probably slightly better than keyhole surgery. However, there's no good evidence that it stops or slows arthritis. There's some anecdotal and circumstantial evidence, but the jury's out on that one. What seems to work, however, is weight loss. If you reduce your body weight by about 5% with developmental dysplasia, you significantly reduce your chance of having a hip replacement a few years down the line. So do we have a future cure for OA then? Well, I'm not sure. The answer is, this is a paper this is the Lancet seminar from 10 years ago. So I thought I'd look to see what was predicted 10 years ago. And it's happened that we wrote this paper 10 years ago. And we thought, well, these are the targets for future arthritis prevention in joints. And a lot of these are still present. So weight loss, there was good evidence at the time. FAI, well, we did some studies, found that maybe it has a good evidence, some evidence for slowing disease, but we're not sure. The jury's still out on that. But most of the other therapies either have fallen to the wayside or have not shown efficacy in terms of slowing the arthritic process. So if you look at the newer publication, which came out, I think, last week, we now see that there are a whole host of new drugs that are out there that are meant to be the next generation of disease-modifying drugs in arthritis. We had these 10 years ago, but none of those worked. It remains to be seen whether these do. They are slightly more targeted in terms of reducing inflammation and aiming to regenerate cartilage, whereas the previous ones were more repurposing of existing drugs. So some of these may work. But what is notable in all of this is the fact that the few studies that suggest surgery might be effective receive tiny amounts of funding, where these are receiving huge amounts of funding for these new pharmaceutical interventions. So what can we say in summary? Well, there are some proven treatments that work. You know, reducing weight, exercise is probably one of the most effective interventions for slowing down arthritis. Joint replacement works beautifully in the hip and the knee. There are no good pharma treatments that we can see, and repurposed drugs such as strontium, that hasn't seemed to been the wonder drug that it was meant to be 10 years ago. There's limited evidence of biologics in small cohorts. Whatever studies you look at, there's no good evidence it stops arthritis 10 years down the line, or even 5 years down the line. And I think the main issue for us is that there's a fundamentally different approach between physicians and surgeons in the way we perceive arthritis and treat arthritis. Some view it, and I think as I do, as a joint-specific approach, and some joints are locally driven, and I think the hip is one of those joints. Others may be more systemic, such as the hand. But I guess the big issue for us is not whether we can treat these, it's whether we can pick up arthritis at an early stage. And it seems intervening at an early stage has better outcomes universally with regard to whether it's surgical or medical treatment. And the key to that is better imaging. And I thought I'd end with just this image here, which shows T2 star mapping, which was meant to be the be-all and end-all of imaging 10 years ago and hasn't yet translated itself into clinical practice, but it can enable you to pick up early arthritis. Anyway, thank you very much for that.
Thank you very much. Yeah, so we'll keep questions for the end. We'll just run the talks back to back. So now I'd like to introduce a good friend of mine, Gilbert, all the way from Norway, and he's going to talk to us about the use of offloading knee braces in the athlete.
Good afternoon, everybody. Thank you for the invitation. It's good to see some familiar faces here. I think it's kind of a stretch to ask an orthopedic surgeon to advocate for braces, but I'll do my best. Those are my disclosures. As you can see, I'm not doing anything with the bracing industry. The aim of the talk, I'll just touch on some of the common causes. Biomechanics, I think when you're talking about braces, it's just trying to address the biomechanics. The treatment options we have, I think when you have to decide on what kind of treatment we choose for that particular patient, we have to also to consider what do we have in our toolbox, what options do we have, and then go on the unloader bracing for OA. Causes, as a great lecture that we just had, I mean, we really don't know much about some of the causes. We usually say it's idiopathic when we don't know the cause of the OA. Is it a systemic or is it mechanical? Is it biology? Post-meniscectomy is what most of us surgeons would see, patients who have had a medial meniscus tear or lateral meniscus tear, meniscectomy, and then developing that. Maybe they have some varus alignment from before. As you can see with some sports, this is one of the best football players to ever grace the football field, Rivaldo from Brazil. And as you can see there, you could potentially pass a football between those legs. And some of that post-traumatic. And biomechanically, they say from studies that 60% of the loading goes through the medial compartment, 40% through the lateral. And this will change if a patient is in varus or if the patient has had a meniscectomy. It will going to change those mechanics. as you can see on the X-ray down on the right. And unfortunately, we as surgeons tend just to think about the mechanics, and that's what I will be talking about, but I think the disease is a little bit more than that. That's why I think with some of the patients, you see the OA, we address the OA, but they're still in pain because it's much more than just the cartilage. What options do we have? I think before we get to the bracing part, we have to look at the options we have. I mean, if you have like 2 bad options, then it's difficult to choose. If you have some good options, then I think that it makes it easier. We have some medication, lifestyle changes, as we talked about earlier on. Physiotherapy, I think, plays a very important role no matter what direction you take. Injections, Ian will talk about injections. We've had a big hope on injections. I don't know if we've come very far in the last 10 years. And then braces that I'll talk about, and then surgery. And I think before you get to the surgical part, even though we are surgeons, you should have tried all of the above options. Brace mechanics, the whole point with braces is trying to address the biomechanical part of OA. That is, when you have I'll focus more on the varus aligned. When you have varus alignment, the whole point is trying to shift that mechanical axis or the loading axis to more laterally, and therefore trying to offload that medial compartment. And as what you see there is what's done with the osteoarthritis, but can you get to the same point? Can you offload using braces? Several studies showing that you reduce compartment forces on the medial side by using a brace. And a study from the Pittsburgh group with Freddie Fu showing that you can actually also increase the dynamic medial joint space by using a brace. A systematic review was also performed looking at the biomechanical studies showing that the unloaded brace actually reduce adduction moment and also by so doing reduces the forces acting on the medial compartment. Does this translate into less pain on the medial side? Because sometimes biomechanical studies and clinical studies is 2 different things. There are several studies that show improvement of knee function. I'll go through a few studies that have been shown that you can improve knee function. And some suggest that you might actually delay the need for arthroplasty, whether that is based on the fact that some people, maybe they don't want to go that route or they are more compliant with the brace. We don't know, it's maybe a selection bias that some patients choose to delay that process, not because So, and the studies have small sample sizes. This is a study that compared unloaded brace versus placebo brace. The braces were kind of similar, but the placebo brace did not have that, the straps that are supposed to apply that moment were different, so they didn't have that unloading effect. And found that unloaded brace was superior in terms of KUS, in terms of function. So those 2 braces, the other one was unloaded, the other one was not doing the unloader. It looks like the unloaded brace was doing a better job in terms of function. And another study comparing the unloaded brace and looking at muscle activity. There have been like some issues where people worry that maybe the muscle activity changes, which might be negative, showing that when you use an unloaded brace, you reduce muscle activity and contraction. And their argument was maybe that the muscle activity that you get with OA is detrimental to the joint and to the function. And by reducing those forces and the muscle activity, you are actually helping the knee load better. Great study from Fowler Kennedy back in the day, looking at unloaded brace versus a sleeve. Showing that there was improvement in both groups, but the unloaded brace was superior in terms of, it was more effective in reducing pain and improving function. So this thing about unloaded brace is not something that is really new, as you can see from that author group that is from way back. Comparing unloaded brace with another brace that is not unloading, but changing the, influencing the alignment, study from Germany, ankle foot orthosis versus unloaded brace, 160 patients. In both groups, there was an improvement. and there was no group difference. They didn't find any difference in groups. So maybe anything that can kind of change how we load the lower extremity could be effective. Some studies suggest, but we cannot argue that based on the other studies that unloaded brace seems to be doing well. I'll just mention this, that unloaded brace, or should you just go straight for osteotomy? As I think osteotomy is a very big procedure, and Andy Williams will talk about it tomorrow. But in terms of these two, when comparing these two, only 51 patients was a very small sample size. H2 was more effective. But it's the procedure, I think before you jump onto something that invasive, you should have tried something else. What are some of the challenges we are facing? It's the data that I presented, the data that we find is mainly based on regular weekend warriors, people, and not so much data on athletes, unfortunately. And when you say return to sport, we're basing on returning to activities, we're based on coups and other factors. We don't know the performance level and activity level. So that's usually one of the problems we are facing when we're talking about return to sports, return to activities. We are not able to really document at what level and how activity level in general. Challenges are the compliance. Not many people are very happy with that. And it's not very suitable for some sports, and some sports actually do limit if you can do that, because the brace should not be giving you an advantage over your competitor. To summarize, I would say unloaded braces have been sent both from the biomechanics and clinical standpoint, have been shown to improve knee function and reduce pain. So there's a good alternative, or maybe adjuvant when you're dealing with these patients before you end up with surgery, and they can be combined with physio, with other injectables and other things that can be used. And then it's important, I think, to try this before you go for surgery, because if they don't respond to this, you might know that they might not do very well with surgery. Thank you very much.
Okay, and I'd like to introduce Ian, and we're going to hear about injectables for OA, clinical rule in 2025.
Great, so we're quite a diverse audience, which is great, really multidisciplinary. And one thing that we all have in common is it's very difficult to get through a clinic or a session without someone asking about injections when we're managing arthritis. So I'm going to move from perhaps what's in the future to really talk about the practical applications when considering injectables for managing patients with osteoarthritis at the moment. And the spoiler alert, as Sean alluded to earlier, is that we are not yet in a position where we are modifying diseases with these injectables. We don't yet have strong evidence to suggest that we can reverse or slow osteoarthritis, but they are certainly tools that we think that we can help to use in our toolbox for modifying symptoms. So I'm going to touch on why we might use an injectable approach at all, what that landscape is in 2025, what are the things that are available, what do I think we could use as our tools, and where I think maybe we should be a bit cautious. So what is the advantage of using an injectable approach over a systemic drug, for example? Well, we know that local delivery increases bioavailability. It can reduce systemic exposure and, as a result, reduce adverse events. But we also know that whatever is injected into the knee, for example, or could be any joint, is rapidly cleared by lymphatic drainage. And the effects that we are seeing beyond that are not yet fully understood. The other major challenge for us is that this is a minefield when evaluating the evidence. We're talking about a condition which naturally fluctuates. People tend to go for the injections when they're in the middle of a flare, and so you might expect, if you have studies with short follow-up, that they would do well at 1 year or 2 years because you've got them when they're at that big peak. This is a great study, and I'd encourage you to read it. This study by Previtali and colleagues demonstrated that over 50% of patients who had saline injections reported reductions in pains at 6 months. And the other thing that we have to consider is both those who are injecting and obviously industry who are developing these products have a vested interest in what we're doing. And that's why I really feel that we must use the level 1 evidence to study, to guide treatment decisions when we're making it at a population level. And that's what we'll talk about. So the big 3 injectables at the moment, we've got corticosteroids, we've got hyaluronic acid or viscosupplementation, and we've got platelet-rich plasma. And then everything below the line are the less frequently used ones, and we're going to just touch on each of these and where we think that they might offer value. So let's start with corticosteroids. I'm sure everyone is familiar with these. So we're talking about synthetic anti-inflammatory agents that can reduce pain by suppressing synovitis and inflammatory cytokines. We have good, strong evidence to show that they're effective at the short-term relief of osteoarthritis, particularly where you have moderate or severe forms. There are some caveats. You can get this false feeling of readiness, this concept that the symptom relief outpaces actual recovery. And so in the setting of athletes or people trying to be active, they could perhaps have a Charcot type effect where they may overload before the knee has, or the other joint has recovered. There are a whole host of different options within each category, and that'll be a theme that we're kind of discussing. And within these themes, they have huge variability. One of the big concepts to consider in steroids is the solubility or the crystallinity of the steroid. So if you've got a very crystalline form of steroid, generally has a low solubility, and so you kind of get a depot effect. So that tends to last longer, but got a shorter outcome. So you really have to think about which option you're using. One of the big things that's been talked about at the moment is chondrotoxicity with corticosteroids. There isn't strong clinical evidence yet for this, but there is definitely in the laboratory setting, multiple mechanisms have been demonstrated of corticosteroids affecting chondrocyte health. These effects are dose and duration dependent, but it seems that single or occasional injections are likely to cause minimal harm. Hyaluronic acid. Now, this is the viscosupplementation group, and this is really to mimic the synovial fluid to try and improve lubrication. There's some data to suggest it may reduce inflammation and improve biomechanics. And as I mentioned with steroids, there is a huge spectrum of preparations. So no two HA preparations are really the same, and that's borne out in the evidence. This is, again, a really interesting systematic review from the group in Toronto, where they demonstrated, this is a meta-analysis, a systematic review of meta-analysis, where they said that HA was outperforming saline, but not to a clinically significant, a meaningful level. So again, like some of the injections, a lot of these studies are done grouping together subsets, and what we're seeing is small effect sizes. Again, there's a whole host of different HA options. One of the things that have been tried to achieve by industry here is to try and increase the duration of time that these products stay within the joint. And that's the rationale between increasing the molecular weight, cross-linking them, or adding them as additives. And there are a number of other strategies that are seeking to combine HA with other strategies like steroid, for example. The limitations of hyaluronic acid, as I mentioned, a very variable response, not recommended for advanced osteoarthritis or inflammatory arthritis, and there are rare but possible local reactions. Platelet-rich plasma is kind of, I guess, the newish kid on the block, or has been trying to be the new kid on the block for the last 10 years. But this is any concentration, any preparation of whole blood with a concentration of platelets above the baseline. So huge variability. Initially, it was thought that these growth factors and cytokines released by platelets would regenerate tissue, but unfortunately that hasn't been the case, and any effects that are attributed to it are thought to be primarily anti-inflammatory at present. We talked about this variability. At the moment, they're generally split into preparations where you have depleted white cells and those that are rich in white cells, and clearly one has quite a number of pro-inflammatory cells, another has less inflammatory. So you can imagine that these shouldn't really be used for the same applications. One of the key things of the PRP data, and there's not many areas in musculoskeletal research where you have 42 level 1 studies. Interestingly, all of these studies, we talked about the challenges of interpreting them, reported a benefit over baseline, very small effect sizes, with leukocyte-poor preparations seeming to outperform leukocyte-rich. But the big limitations we have here is the huge variability in these preparations. What you have for breakfast affects what's in your PRP. There's good data from this Stanford group, Connie Chu, who has shown that some people make better donors. And certainly, this concept of having responders and non-responders is something we're more likely to understand as we tease out the various phenotypes of osteoarthritis. So this is what the national guidelines say about the big three. And you can see that certainly for PRP, you get huge diversity in what's being said. So for corticosteroids, and in this setting, we're really talking about short term, this is supported as a tool by almost all of the groups. Hyaluronic acid is getting a bit of a mixed review, and that's because of these studies, these big meta-analysis, although once again, these are often studies that include a whole range of different preparations. And with platelet-rich plasma, you've got the ESCA group in Europe who think that everyone should have it for breakfast. And then you've got others like the rheumatologists in America who strongly recommend against. And part of that, I think, really is the variability in the quality of the studies. So just as we kind of get closer towards the end, I just want to touch on cell therapies, because again, everyone's asking about stem cells. And the key thing that we're talking about here are these mesenchymal stem cells. But this term stem cell should really be banished from our language, I would suggest, because the cells that that are being described as this don't actually demonstrate the attributes that you would think of with a stem cell. They're not self-renewing, and they're not differentiating into multiple lineages. So it really gives patients this false idea of regeneration, which in fact is just not, it just has not been demonstrated. Again, you can isolate these cells from everywhere. The most popular options at the moment being from bone marrow and fat, with varying degrees of preparations. But in these settings, they are relatively high in cost. They can be associated with invasive harvesting procedures. There is very limited high-quality evidence, and as a result, the long-term safety data is lacking. And of course, when we are talking about these more purified preparations, which have been to the laboratory, this comes along with regulatory restrictions. Other novel therapies. Every week we have patients coming to clinic who bring a flyer or a pamphlet or a printout from somewhere online where they've got new preparation. One of the big ones you might see are hydrogels. This is like arthrosamid, for example. This is a non-biodegradable polyacrylamide preparation that stays within the knee. And again, its mechanism is not well described. And these others also include exosomes and amniotic fluid. And I think my key message here is that these are high cost, often marketed directly to patients. They don't have clear benefit over the more established options, and we can't be absolutely certain that they're safe. So I want to close just by saying that I think it's really important that we're careful with the language and the expectations that we set for our patients when we're talking about injectables. We're unlikely to be modifying disease, and we really should be very transparent about that, because even in the UK, 80% of the clinics that are advertising cell-based therapies are making unsubstantiated or misleading claims. So in conclusion, I do think injectables are a useful tool, particularly in an individualized approach. I think there is a role for steroid PRP in HAs in the various individual circumstances. I do think there is limited evidence to support the other available novel injectables, but the key thing is we have to be open and transparent with patients about what we're expecting to achieve. Thank you.
Hear, hear. Now I'd like to invite Dr. Alistair Nicholl, sports and exercise medicine physician, but currently working within Formula One, going to tell us about the practical management of athletes in season and in competition.
Thanks very much. Thank you very much to the organising committee as well for putting on a fantastic programme today. I'm going to try and avoid duplication here by going a little bit off-piste to start with. I'm not going to go into the detail of tomorrow afternoon, but my first question is, can we prevent the major ligament injuries? Again, it's not a spoiler alert. I don't think we're going to be able to influence that massively. I think we can definitely improve, but we're still going to have ACL injuries. So if we're going to have ACL injuries, can we impact then on the development of the post-traumatic osteoarthritis? And I'd like to just identify and make you aware, many of you will have seen it, of this paper that was published a couple of years ago Jackie Whitaker and Kay Crosley from La Trobe in Melbourne done a fantastic job of putting this together. Bottom line is, it's a consensus framework. And my understanding of a consensus framework is you put that together when there's not enough evidence to produce clinical guidelines, so you pull an awful lot of the evidence that is out there, and they've done a great job. They do say at the start that our understanding and the prevention strategies in place for post-traumatic OA is pretty slow, if not non-existent in some places. I know that many of you are surgeons, and those that are, I'd be interested in knowing how much time we spend talking about when we've got an ACL and we're talking about a reconstruction, how much time we talk about that 5, 10, 15, 20 years later, and how we promote knee health at that stage when the other person on the other side of the table is probably interested in returning to their activity. Whether they are community level physical activity proponents or elite athletes. They want to get back to it, and many of them are not interested at that stage on the longer term benefits. So the whole idea of here is that they've made recommendations for research as well. They're very much a research group, but the clinical side, again, it's not rocket science. They want to make people aware of post-traumatic OA much earlier on so that you can promote, and I think it's one of the first times they talked about the principle of knee health, which is something that I don't think over the years I've used that term, and I think it's probably quite a positive one, and it just gives us options to look at of how we can prevent knee OA and developing in the future. This was another very good paper which again highlights the fact that, are we giving the right advice? And this is basically looking at post-knee surgery returning to running. Many would say, well, actually, that's probably not very sensible. But if that's all people want to do and there's no other modifiable risk factors that are stopping them, then should we be saying don't return to running? But this highlights some of the challenges and again brings up the term knee health. So post-surgery, should we be thinking quite early on about how we promote knee health rather than waiting 5, 10, 15 years later when we start seeing the symptoms of post-traumatic OA. But most of those guidelines are targeting the non-professional sports athlete. And I don't call them elite athletes because, as you know, there's an awful lot of professional athletes that do it as their job, and certainly they might not be described by many as elite, but they are professional athletes. There's human factors to be considered here, many of them that you probably identify. If they're coming up for contract renewal, I need to be playing. Nearing the end of a career, option of going out to Japan, going out to France for a couple of years to make some decent money, financial stability, I need to be playing. I've been in an academy, I've been in pathway programs, I've been a professional for 12 years. What else am I going to do? Despite the pain, I still enjoy it. Enjoyment's not enough. They need to be performing because they're not going to be selected if they're not performing. And this morning, we had Phil talking about some of the mental health, huge mental health challenges. Many of you that have been patients will know it's not great fun. If you're on something like a rehab post-ACL recon program, when we talked about 5, 6 months, for most of us it would probably be 11, 12 months. If you're not training with everyone else, mentally it's tough. The good clubs manage to keep the fit squad and the rehab team together, maybe at morning coffee sessions, lunch sessions, everyone's together. But too often it's easy when they're injured and they're on the rehab pathway that they're separated. They don't have the banter in the dressing room, and if they're in a single isolated sport, for example, like golf, they might come across others on the driving range, but that's the only time. They're not going to be getting out in the course. So I mentioned poor lifestyle choices. We know that alcohol, misuse of drugs and gambling are associated with people on rehab programs, not for the positive, but because of that isolation and things that was mentioned earlier. So I'm just going to take you through a case. 32-year-old footballer playing in the Scottish Premier. I'll let you decide whether that's elite or professional. 2 years to go in the contract. ACL rupture and a medial meniscectomy 11 years ago. Bone patella bone graft done. RTP was within 8 months, so pretty good return, and has been a regular for the club for the last 10 years. But in the last 4 months, developing what they describe as deep medial knee pain and regular swelling. So small knee effusions after training and matches. X-ray is showing quite extensive medial compartment OA. So clearly this chap needs to be performing. And to me, that's the difference with a professional athlete. They need to be out there. They're not going to get another contract if they're sitting on the sidelines. They're not going to get a contract if they are only able to play once every 3 weeks. So can we buy time? And I'm glad to see that my list is pretty similar to Gilbert's list, although I haven't put braces on here, because I don't think that's an option in contact sports like football or collision sports like rugby. You're not able to get away with it. If you're playing golf, you can wear an offloader brace, and therefore that's another option. So there's a few options there, and for want of trying to wake up a few of you, I'm just going to ask the questions. What do you think we should start with off that list? Anyone want to throw one in? Load management. Okay, can I suggest that that's probably not what we're going to start with at the moment? Medication. I'd be looking at something first. I'm not right, by the way. I'm just giving you an opinion. Yeah, so strength training. I think, again, if we step back and say, look, we know someone's had an ACL, do we wait till they're symptomatic? Or is this maintenance? So someone that's got that sort of history, we really should be looking at a maintenance program to ensure that they are maximizing with their conditioning their strength around that knee and proximal and hip. So that should be fairly standard maintenance. We shouldn't be waiting till they're developing symptoms. What about supplements? Okay, so again, the evidence for supplements is pretty low. However, there's very little evidence of harm, and you would not be surprised in clubs like that they would have chondroitin, glucosamine, maybe fish oils to potentially help keep that joint in a reasonably good condition. Medication, yeah, I think that can be switched on and off. If it works well, great. If it's not working, there's no point having it. So definitely worth trying. And there's a few options out there, which we don't need to go into the detail now. Injections, you just heard from Ian that there are a few options out there. I wouldn't be thinking of injections until we talked about load management. Just before I do that, I'll just mention the surgical side here. That knee X-ray in this guy might be suitable for a uni-compartment knee in a few years. But we're not talking about a few years at the moment. We're talking about how we get him through the rest of this season, potentially looking at that contract for another couple of years. So load management is the absolute key in this sort of player. And the focus for load management has to be on playing time. And what I mean by that is that there's no point training well but not being fit to play, because that's what they're paid to do. So they can spend as much time training, and we need to manage that. If they've got a good coach, manager that says, look, okay, we'll only pay you for 40 minutes, then that's a bonus. But depending on what sport, rugby, we've got many of the front row will only ever play 45 minutes. Or if they're on the bench, they come on and they play 35 minutes. in football and soccer, with less number of replacements allowed, you're probably going to be playing longer. So depending on what sport you are, you need to be performing. And I think that, to me, that's the absolute key here, is in professional elite sport, they need to be performing, whereas our non-elite population, non-professional population, we can focus on even changing sport and function being the key. So I would go as far as saying post-traumatic osteoarthritis is probably inevitable. You can wrap them in cotton wool, but then you start developing other metabolic problems. So I don't think that's an option. The key with that population is function, pain and function. And you may have to change your activity to allow that, but pain and function. Whereas the professional athlete, it's absolutely performance. If they're not fit to do that, they will not be offered that contract. And the fundamental key in all of that is load management. Thank you very much.
So I'd like to invite all our speakers up to the stage. Alistair, if you can come back up as well. Maybe get one extra chair in if you want to bring a chair with you.
I think you'll all agree that's been a fascinating journey through the role of different doctors and osteoarthritis, and I'll let our colleagues sit themselves down, waiting for a duet of questioning questions. Alistair, I'm going to jump to you. Is sport safe? We've been talking about safe sport beforehand, but no, is sport safe for joints?
Yes. Would you like me to follow that up? I think the benefits of physical activity will vastly push you in one direction, and some sports, the injury risk, and whether that's a musculoskeletal injury or concussion, there is a small risk. I think that all the positives outweigh the negatives. So injuries will happen. We accept that. We try and minimize that, but we accept that. But no reason not to be active.
Yeah. I loved your term around knee health. I think we need to recognize that the knee's attached to the hip bone and the hip bone's attached to the rest. So I guess we could talk about patient health or joint health. When does that start? When do we actually intervene on joint health?
Do we wait till they've had a first ligament injury? And the straight answer is we probably shouldn't, but I suspect that we probably do, that we don't bring that, the injury prevention side in early enough.
I'm going to keep you in the hot spot, Alistair, if that's okay. As a knee surgeon, how do you talk about load management, I want the tips and tricks of how you manage load in a professional athlete. Because I have athletes with focal articular cartilage defects. You say that they need to be strategic and load manage, but they are competitive and they want to play and they want to be the best at what they do, and they ignore your advice and they blow the effusion and they drive the chondrolysis. So I want technical tips and tricks. What do you do to get them to manage their load?
I'm probably the wrong person to answer this. We've got Enda sitting in front of me here, who I'm just looking at the practicalities of load management and the key principles. We need to look at all the things that add load to, for example, let's just talk about a knee. So there's no point looking at the rehab program if they're cycling 5 miles there and back, for example. So there's other activity beyond what we call the rehab program, or they go back and they walk the dogs for a couple of miles. So it's 24-hour rehab. We've got to look at the load in all that time. We would sit down and look at what's required. We talk about the acute and the chronic side on loading and things. The practicalities are, what can we get away with that allows us to get them on the pitch and performing let's just say at the weekend. So I'm not going to give you a detailed programme, and I'm sure you weren't asking for that, but the key principle is what's good for one person is probably not the same for someone else.
Thanks, Alistair. Ian, corticosteroids, athletes, is that a good mix? Or as a sports medicine physician, am I just overly cautious about the role of corticosteroids?
Well, I mean, I think a key point is that in the setting of osteoarthritis, that might be, there's lots of ways I think that we can use corticosteroids for different settings. You know, we can use corticosteroids with local anesthetic for diagnostic injections if we're not sure what the cause of something is. So I think the key thing is that we have to remember what are we actually trying to achieve with the corticosteroids. So we're specifically talking about osteoarthritis here. So in that setting, I think I do use corticosteroids. I might get in trouble from certain people here, but I think you have to really take some information from the patient in terms of where are they in that journey. And I think the role of corticosteroids for me are those patients with more advanced osteoarthritis who are in a flare at a very bad time for them, for example, in the season. So I don't think it's something that I have this is my algorithm for this and that, but I think it has a role in certain settings. But I absolutely agree the things you need to watch for are joint overload, that Charcot effect, and multiple injections. So,
Thanks. Alistair, you wanted to say something also?
Yeah, I was just going to add that injections at the right time will be hopefully help. The one thing that's probably changed in the last 10 years is our understanding now that the corticosteroids can be chondrotoxic. So we maybe didn't talk about that before. It was a quick, an easy fix. If you've got a joint that's already the meniscus, for example, or the chondral cartilage is worn away already, then they are well down that route. Is one injection going to make a massive difference if it buys time 3-4 months at the end of a season, for example? So it's that balance. We know it's maybe not good for the knee, but in terms of function, pain, and the ability to continue to play, if they're aware of the risks, then that would definitely be a worthwhile option.
We have a question from the back of the room.
Can I ask a specific question about that? Because we all know athletes who have had arthroplasty. When would you avoid corticosteroids in terms of an impending joint replacement?
I would say, what's the risk for that patient? If we know we're going for an arthroplasty, and whether, let's say, the knee, whether that's a uni compartment or a total knee, and you know it's coming, then might the corticosteroid injection buy you a little bit of time? If that's happening next week, you're not going to inject. If you want to push it to the right as much as possible, then I would still consider it.
I'll come in there and say, I mean, there's obviously some absolute contraindications for corticosteroids if you're concerned about infection, if the surgery is imminent, or if they've had a history of a flare reaction. But out with those instances, I agree with Alistair.
Just sticking on the injectables, I'm just going to ask the panel, who do you think should be responsible for the governance around injectables? So you've quite clearly demonstrated the lack of level 1 evidence, the lack of robust research. We have a fiscal responsibility as surgeons to our health economy. So should this be something that our professional society should weigh in more on, so that these mesenchymal stem cell clinics aren't popping up everywhere? Ian, do you want to lead in that?
Yeah, I mean, I think that one of the major challenges we have with regulation of these injectables is that we're talking about bodies that have financial constraints, and where no major harm is being done, it becomes less of a priority, and we've seen that both in the US and in Europe. So where people may be making money, but the patients are not seen to be at major harm, it is understandably taking less priority. So for example, the Advertising Standards Agency or the regulators. It's just, there's limited resources and it's just not high up enough. And as also seen, as you've seen with the various governing national bodies, I didn't put it up there, but for stem cells, they all say should not be used, but people are still selling them. So.
Hear me? Yeah, it's
Yes.
on. Cool. Jane Johnston, podiatrist, so you probably know what's coming. Lateral wedged orthotics, why was that not an option for treatment in your case study, Alistair? When we know it reduces, well, it may reduce cam angle and also the symptoms in the medial knee joint.
Very good question, Jane. Yeah, I didn't know you were here, or I would have put it in. And I did wear your lateral orthotic for many years.
That's grand. Catherine, sorry, there's a microphone coming your way. Oh. Thanks, Catherine. I'm just going to repeat that just to say in terms of it's to do with consent and the risks and benefits given everything that we've seen today. So apologies, the microphone wasn't working there.
I mean, that's a really good question. I mean, it is a different consent process. So compared with your average patient, I would normally counsel them for the additional risk of career, impact on earnings. You know, these things are difficult to quantify, and you know, I think it's incumbent on us as surgeons to say, look, you know, to divorce the population risk of improvement versus the individual risk of improvement. And this always comes loaded quite often when they come to clinic with you. The expectations are that you're going to provide a cure, and I think we just need to be very realistic with them about this, both ending their career, their surgery, and potentially not making a difference.
If I could just add, it's easy to be principled up here. When you've got a professional athlete in front of you that is trying to keep their career on the line or extend it, then you need to have some honest chat, and quite often they're prepared to take a 40% chance that it might not help them, but there's a 60% chance perhaps that they'll get better. They would definitely take that.
I think like one of your slides, when you're looking at what people want from, I think with every patient that you have to understand what are the goals. And my goals and somebody else's goals are completely different. I think that's the basis for understanding what their plan is, what their goals are, and trying to work towards those. I mean, mine is maybe just to run once a month, and for them it's professional, and balancing those things. I think how do you help them get to reach their goals and others?
Gilbert, I've got a question for you about post-operative use of knee braces. We've just recently seen a world-class skier, Lindsey Vonn, return from hemi-joint replacement of a knee. Would you recommend, I appreciate you don't know all the details behind the scenes, but would you typically recommend high-force sports like skiing, ice hockey, ice skating to use a brace post-operatively?
I don't have any science behind it, but we usually recommend them the first season.
Okay.
To use a brace.
That's great. Thank you. Sean, I've got a question for you. You put up a wonderful slide there looking at the differences of hip issues, FAI and CAM, and really noticing the difference between men and women, and with women almost being a very small hint of a positive blip versus men having significantly more issues. Is that really the case, or is it just that we've not seen the tsunami that comes with women who are now engaged in more professional and top-level sport?
Yeah, I mean, I assume you mean in terms of the prevalence of large cams. So, you know, the prevalence of large cams is obviously much greater in men. We know those large cams have a higher risk of osteoarthritis progression. Sometimes, you know, within 5 years, you know, if your alpha angle is bigger than 100, it's about a 20% chance of OA progression within 5 years. That said, it depends on the sport. So, you know, if you're a female professional rower and you've got a small cam and you're flexing your hip under load up to 140 degrees every day on an ergo on the water, you're going to have problems at a much earlier stage than, say, a runner with a large cam, a male runner. So I think you have to take these things in the context of the sport they're doing and the activities they're doing. But those, as you say, those small cams may actually be more damaging in some circumstances because of activity.
That's great. Thank you very much.
Any other questions?
Any other questions? No? Well, if we could maybe give our speakers a round of applause, please. You'd be glad to know that coffee is served downstairs as well as the exhibitions. See you back in 30 minutes' time.